Despite decades of awareness of residual neuromuscular blockade, it remains a major patient safety issue. Without any objective quantitative monitoring, up to 65% of patients may leave the operating room with residual neuromuscular blockade. This is not a minor complication. It's a significant patient safety crisis. Residual neuromuscular blockade, which is defined as a train-to-floor ratio of less than 0.9, is directly linked to an increased risk of postoperative pulmonary complications, upper airway obstruction and hypoxia, impaired swallowing and aspiration risks, as well as a prolonged PACU length of stay, which tumble downhill to a variety of other additional financial considerations. The real problem, though, is that we do not recognize many of the adverse or non-routine events in the PACU as being related to residual neuromuscular blockade. And what do I mean by that? Well, this is really a blind spot of ours. We think we're doing fine in this space, and in large part, it is all due to classic cognitive bias. If you ask your colleagues at work tomorrow how many folks have seen any evidence of residual neuromuscular blockade, most would say they've never seen it. It's not a problem in their practice. A few who've been in practice for quite a long time may report seeing it, and some may say, well, I saw it when I was a resident, but that was probably because it was a resident that was care of the patient and they, underdosed or didn't read the signs properly. The other point to cognitive bias that really blinds us is that there's a total lack of feedback. We discharge our patients from the PACU, not really paying attention to necessarily how long they stayed, but we don't follow the patients to the floor or at home. So some of these patients go home and end up back in the operating room 2 days later with a pneumonia, or they go to the floor and end up re-intubated in 24 hours. Most of the time, we aren't aware of this. Frequently, these issues are attributed to some aspiration, which often gets bundled into, well, it happened sometime after the OR, but nobody goes back to truly tie it back into the fact that perhaps they weren't fully reversed in the PACU after all. The last issue is one that we always have, availability heuristic related to the recency effect. We remember the 99 cases that went smoothly, not the one that had a subtle delayed respiratory complication in the PACU. So where are we? Quantitative neuromuscular blocking monitors are a fundamental safety monitor. It is not just a new gadget that we get to play with. Its adoption in our practice is as critical as the other monitors that have created our modern standard of care, right? If you think about it, we would never accept clinical signs like, well, the patient looks pink as a surrogate for actually using a pulse ox, right? We would never accept the idea that, well, I can feel the bag moving as the patient is breathing, so clearly that's a good indication of some degree of end-tidal CO2, right? So if that's the case, why in the world would we accept simply watching the thumb in place of an actual quantitative train-to-floor ratio? The 2023 ASA guidelines have officially moved quantitative monitoring from a suggestion to the recommended standard of practice. The question is no longer, why did you monitor, doctor? The question is now, why didn't you monitor?